Hello friends, I am Dr. Sarita Jain. In today's video, I will be discussing about diagnosis and management of the hyperprolactinemia. So first of all, what is prolactin? Prolactin is a hormone produced by the pituitary gland and it is essential for producing breast milk after childbirth. It also regulates reproductive function by controlling other hormones like luteinizing hormone and follicle stimulating hormone. Now, what are normal prolactin levels? In people assigned male at birth, normal levels are less than 20 nanogram per ml, and in people assigned as female at birth and non-pregnant and non-breastfeeding, levels are less than 25 nanogram per ml. People who are pregnant or breastfeeding, levels are between 80 to 400 nanogram per ml. Now, what is hyperprolactinemia? Hyperprolactinemia is a condition where prolactin level exceeds the normal upper limit set by the laboratories. And why it is important to measure the prolactin levels? Because it affects reproductive health and functions. So, it needs proper diagnosis and management based on the underlying cause. Now, what is the prevalence in general population? About 10% of the people may have elevated prolactin levels. Now there are certain groups which will be more commonly affected with this problem. In women with oligomenorrhea, with amenorrhea and with complaint of galactorrhea and infertility, this is found more frequently. Likewise, in men with complaint of hypogonadism, that is reduced function of the gonads, with impotence and with infertility, this is found more commonly. About 9% of the women with amenorrhea, 25% of the women with galactorrhea and up to 70% of the women with both amenorrhea and galactorrhea will have this problem. Likewise, about 5% of the men with complaint of impotence or infertility will be having this problem. Now, how prolactin level is regulated? It is mainly controlled by the signals from the hypothalamus. Main inhibitory signal is dopamine from the hypothalamus. It prevents the release of prolactin from the pituitary and this is predominant signal under most condition. Main stimulatory signal is thyrotropin releasing hormone from the hypothalamus. It stimulates the prolactin release and balance between dopamine, that is inhibitory, and TRH, that is stimulatory, determines the amount of prolactin released by the anterior pituitary gland. Now, what are the symptoms of hyperprolactinemia? There are few symptoms which are common for both sexes. These are infertility, loss of interest in sex, low bone mass, milky discharge from the nipples, when not pregnant or chest feeding, that is galactorrhea. There are few symptoms which are common in females. These are changes in menstruation not related to menopause, such as irregular periods or no periods, that is amenorrhea, pain or discomfort during penetrative sex due to vaginal dryness. There are few symptoms which are more common in males. These are erectile dysfunction, low level of testosterone, gynecomastia. Now, there are some symptoms which are associated specifically with prolactinomas. These are headache, often persistent and can vary in severity, nausea and vomiting, especially if the tumor causes pressure on surrounding structures, vision changes such as double vision, decreased peripheral vision or other visual disturbances. These are mainly due to the tumor pressing on the optic nerve or optic chiasma. There can be sinus pain or pressure which is experienced due to the location of the tumor in the pituitary gland. Sometimes there can be problem with the sense of smell, that is anosmia or hyposmia, which can occur if the tumor affects the olfactory nerve. These symptoms can vary depending on the size and location of the prolactinoma within the pituitary gland. Now, what are the causes of hyperprolactinemia? Among the common causes are prolactin producing tumors, that is adenomas in the pituitary gland, inflammation of the pituitary, that is hypophysetes, condition that reduces the dopamine levels or delivery to the pituitary, some condition that increase the TRH activity, few medicines with anti-dopaminergic properties can increase the prolactin production. These medicines are high blood pressure medicines such as calcium channel blockers, example verapamil, tiltiazem and methyl dopa. Certain antipsychotic medication like risperidone and haloperidol, medicines for nausea and vomiting, example metoclopramide, medicine for heartburn and GERD like proton pump inhibitors, birth control pills, especially those containing estrogen, some pain relievers containing opioids such as codeine, morphine and tramadol, medicine for menopausal symptoms, mainly HRT which contains estrogen, and some peripheral triggers such as chest wall injury and breast stimulation can reduce the dopamine release, and also if there is impaired clearance of prolactin from the blood due to the renal or hepatic issues. Now what is macroprolactinomas? These are moderately elevated prolactin levels with no symptoms or reproductive issues. These are caused by prolactin molecules forming a polymer. Prolactin polymers are detected by the serum assays but do not affect the prolactin receptors, and they result from the prolactin binding to IgG antibodies, and usually they do not have any biological effect. Now what is macroprolactinoma? These are large pituitary tumor which has size more than 10 millimeter in diameter. Now, how to diagnose hyperprolactinemia? It can be diagnosed by the serum prolactin levels. Level between 20 and 200 nanogram per ml can indicate the hyperprolactinemia from various causes. Level above 200 nanogram per ml suggests the presence of prolactin secreting pituitary tumors. MRI of the pituitary fossa can be done to detect pituitary tumors, especially prolactin secreting adenomas. CT scans usually not sensitive enough for small or isodense lesions. Now what is the relation between prolactin levels and the tumor size? Usually high prolactin level correlate with the large prolactinoma. Mildly elevated prolactin with large pituitary tumors suggests a known prolactinoma or other cellular mass causing the compression effect. Now what is the natural course of the prolactin secreting microadenomas? Usually over a 10 years period, risk of prolactin secreting microadenoma progressing to macroadenoma is very small. It is about 7% only, and in some patients prolactin levels return to normal without treatment or with intermittent treatment using dopamine agonist. Also there is high remission rate in women with prolactin secreting microadenoma who become pregnant. It is about 35% compared to those who do not become pregnant, that is only 14%. Now how to manage hyperprolactinemia? Objective of treatment is to normalize prolactin levels to mitigate the symptoms of hormonal excess, example galactorrhea, menstrual irregularities and hypogonadism. To alleviate the symptom caused by the large tumors such as headache, vision problems and other mass effects, and to prevent tumor regrowth. Medical therapeutic options for the management of the hyperprolactinemia are dopamine agonists. These are currently the first therapeutic option. They have proven efficacy in reducing the prolactin level, restoring ovulation in premenopausal women and restoring gonadal function in men. Prolactin levels may remain above normal in about 20% of the cases of macroprolactinoma and about 10% of the cases of microprolactinoma despite dopamine agonist therapy. Bromocriptine has been used the longest, but cabergoline has a greater affinity and selectivity for pituitary dopamine agonist, and it has longer duration of the action. It is indicated in cases of bromocriptine resistance or intolerance. Indication for surgery are reserved for patients who do not respond to medical therapy or who cannot tolerate medications. This is mainly used to relieve the compressive symptoms from the macroadenoma, and transphenoidal surgery is the approach of choice for pituitary tumors. Post surgery, regular follow-ups with MRI scans are done to monitor the tumor recurrence, and measurement of prolactin levels are done routinely to ensure that they remain within the normal range. Approximately 50% of the patients experience recurrence of hyperprolactinemia within 5 years post-surgery. In some cases, radiation therapy may be used post-surgery to prevent regrowth. Now, how to manage hyperprolactinemia in pregnancy? Management of hyperprolactinemia includes diligent monitoring and follow-up, especially for patients undergoing dopamine agonist therapy. There is no evidence of increased teratogenicity with bromocriptine or cabergoline used during pregnancy. Also, there is no evidence of increased risk of abortion or multiple pregnancy with dopamine agonist use. If the tumor size before pregnancy is less than 10 mm, dopamine agonist therapy is stopped during pregnancy because the risk of tumor expansion is low. If the tumor size before pregnancy is more than 10 mm, bromocriptine use is advised during pregnancy to avoid significant tumor expansion. All patients should be evaluated every 2 months during pregnancy. Visual field testing is indicated in patients with symptoms or a history of macroadenoma. If visual field defects develop despite dopamine agonist treatment, early delivery or pituitary surgery should be considered. Most patients show noticeable biochemical and clinical improvements with dopamine agonist therapy. Approximately 80% of the macroadenomas exhibit tumor shrinkage with treatment. Lifelong treatment may be necessary as discontinuation of bromocriptine often leads to hyperprolactinemia recurrence and tumor regrowth, particularly if therapy duration is less than 2 years. Studies indicate that 6.6% to 37.5% of the patients maintain normal prolactin levels and avoid adenoma re-expansion after therapy withdrawal. After 2 to 3 years of normal prolactin levels, consider gradually reducing the dopamine agonist dose. If prolactin level remains stable for 1 year at a reduced dose, therapy can be stopped. Reduce the dose by half over 3 months with monthly prolactin level measurements. After stopping treatment, monitor clinical symptoms and prolactin levels regularly. Measure prolactin levels monthly for the first 3 months, then every 6 months. This was all about the hyperprolactinemia. If you found this video useful, please like and share the video and subscribe my channel. Thanks for watching.